Hello students, welcome to BluepenOnline classes. Hope you all are doing good. Myself Dr. Annu, and we will be discussing on the topic exodontia. So what is exodontia? How can you define exodontia? Exodontia can be defined as a painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals uneventfully and no post-operative prosthetic problems are created. This is how you define exodontia. I hope this is clear. Now let's go to the indications of extraction. What are the indications? Caries. When you have a non-restorable caries, definitely you have to go for either RCT or extraction. Now patients, because of some financial issues, usually opt extractions, right? So that's an indication. Pulpal necrosis, irreversible pulpitis cases, right? Now if it's a failed RCT case, if it is untreatable case, calcified canals, tortuous canals, all these cases you can go for an extraction. When the patient is having periodontal disease, excessive bone loss, tooth mobility, okay, when there is an orthodontic need, like when the patient is having a crowded dentition, you have to go for an extraction, right? When there is a malpose teeth, when there is a cracked teeth, like fractured crown and root. Now impacted teeth, okay, we will deal with impaction later as a separate topic, but still, what's an impaction? What's an impacted teeth? It's a teeth which is unable to erupt into the functional occlusion. Might be because of the lack of space. It can be because of interference from the adjacent teeth. Either of these reasons. Then supernumerary teeth, which actually interferes with the eruption of teeth. In these cases, you can go for an extraction. Teeth which are associated with pathological lesions. Okay, radiation therapies. If the patient is going to undergo extraction, soon after a radiation therapy, you can't do it, right? It's a contraindication. But the patient have to do the extraction process if the prognosis is really poor just before going for a radiation. So that's important. So the term radiation comes both in indication and contraindication. In contraindication, we say just after radiation you can't go and take a teeth. Okay, that can result in many other problems that we will deal in coming sessions. Okay, indication means before going for a radiation therapy, you have to see whether there is any bad prognosis to poor prognosis to, and you have to extract it. Then teeth involved with jaw fractures. Definitely, yes, right. Now financial issues. Oh, very important thing. The patient is having a financial issues. If the patient is not willing to do an RCT treatment, definitely you have to plan an extraction, right? So these all are the indications. I hope this is clear for you. And contraindications, we have systemic contraindications and local contraindication. We will see the systemic contraindications first. In cases of uncontrolled metabolic diseases, uncontrolled leukemia, uncontrolled cardiac diseases, malignant hypertension, pregnancy, it's a related contraindication. Okay, you can do the procedures in the second trimester, but better avoid it in the first and third trimester. Then severe bleeding diseases like hemophilia, right? If the patient is taking corticosteroids, immunosuppressants, bisphosphonates, cancer chemotherapeutic agents, in all these cases you have to take care. Then local contraindication. What are the local contraindications? Extraction in the area of radiation, right? I hope you remember. Teeth located with a malignant tumor, severe pericoronitis around the impacted third molar. These all are local contraindications. Actually, acute dental-alveolar abscess is also a local contraindication, but if you have good access to the teeth and you can have a state of profound local anesthesia, then actually you can do the extraction. So you have to see the situation and then work on it. So these are the different operator positions for the different quadrants. As you can see, for the lower right quadrant, it's 10 o'clock position. Okay, it's 10 o'clock position for the lower right quadrant. Now when it comes to the lower left quadrant, upper right quadrant and upper left quadrant, it's 7 o'clock position. Okay, so I hope this is clear. This is a very simple concept. So this is how the operator stands while doing an extraction procedure. So here you can see the picture of a forceps and some of the elevators. I hope the forceps, the different types of forceps and the elevators are clear for you already from your clinics. Now let's see which all are the different parts of forceps. And forceps, you can see there are 3 parts: beak, hinge and handle. Right. And when it comes to elevators, as you can see in the picture, you have a straight elevator, you can have Warwick James, you have crier, you have window, you have crossbar. These all are the different elevators available. Right. But what is important to us in a point of view is a mechanical principle. What all are the mechanical principles? That is what is important to us from the exam aspect. Okay. So here we have 3 principles. We have lever principle, we have wedge principle, and we have what? Wheel and axle principle. The first one, when there is a lever principle, this is actually based on 3 basic concepts. Okay. First one is the fulcrum, second one is the effort, and third one is the load. Fulcrum, effort and load. Okay, and here we have 3 types. Okay, first order lever, second order and third order. And the first order lever is a principle that we use in forceps and elevators. Now let's see. So as I told you, we have 3 types of levers: the first order, second order and third order. And the only difference between this first, second and third and the placement of the fulcrum, effort and the load. As you can see here in the first class, you are having EFL. Right, EFL. Then when it comes to second class, it is ELF. Now load is in this middle, right? Here it was fulcrum, here it is load. Now in the third class, it's LEF. Now effort is in the middle. Right. This is how we actually classify the different types of lever: first class, second class and third class. Now what is the first class lever? So the first class lever, as you can see in the picture, fulcrum is in between the effort and the load. I hope you're following. See this picture? The fulcrum is in between the effort and the load. And here, as you can see, the effort arm should be longer to gain the mechanical advantage, right? This arm should be longer in order to get a mechanical advantage there. The force, we apply the force in the long effort arm, right? Consider this as your forceps. We apply the force in the long effort arm and the advantage is gained here, which is a short arm. Now let's make this more clear. Let's take the example of elevator for the first order lever principle. Here, when it comes to elevator, we consider the handle of the elevator as the effort arm. Okay, the working end which actually engages the tooth, this is a load. So this is how the first order lever works. Okay, so if it is in the case of mandibular premolar teeth, you will first place a purchase point in the tooth like this, which creates a first class lever situation. Now the crane prick is inserted into this purchase point and the handle forces apically. Tooth is elevated occlusally out of the socket with using this bone as a fulcrum. This is how you do the extraction with the elevator in the case of first order lever. Now let's see how this happens for a forceps. Now here the hinge of the forceps actually acts as a fulcrum. The beak, okay, the beak is a short arm, handle is a long effort arm, and load of course is a tooth to be removed. I hope this is clear. This is the first lever type. Okay, this is actually followed by straight and coupland elevator. Here the fulcrum is in the middle, the hinge of the forceps. As I told you, fulcrum is in the middle in the case of first order lever. So the fulcrum is as a fulcrum is in the middle, the hinge acts as a fulcrum. The beak is a short load arm. Then you have the long effort arm, and the teeth is a load to be removed. You actually give the force through the long arm. The mechanical advantage is seen in the short arm, and this results in the extraction of teeth. Hope this is clear, right? Now what is the wedge principle? What is wedge? What is wedging? Okay, this is actually followed by straight elevator. So to define wedge, a wedge consists of two movable inclined planes. Okay, two movable inclined planes. It's having a base on one end and blades on the other end. Right, and this overcome large resistance at right angles with applied force. This is how you define wedge. Now let's make it more simple by taking the example with the elevator and forceps. Okay, now here when you're exciting a tooth, what do you actually do? This is a straight elevator. You actually place it between the tooth and the bone as a wedge. I hope you're following. You'll place this elevator as a wedge in between the tooth and the bone to separate the attachment of the periodontal ligament from the bone. And this helps to displace the tooth root from its socket. This is how you apply the wedge principle. Now let's see, same in case of forceps. In case of forceps, what do? You insert the tip of the forceps between the mucoperiosteum and surface of the tooth, right? Like this. And when the beaks are inserted further, the mucoperiosteum actually gets displaced and the sockets get expanded. And this actually helps in the extraction of teeth. I hope this is clear. This is a wedge principle. Now what is the wheel and axle principle? What is the wheel and axle principle? And this is followed by what? Cryer's elevator, right? Wheel and axle. Right. The effort is applied at the circumference of the wheel, which turns the axle so as to raise weight. This is the simplest type of principle, right? The effort is applied to the circumference of the wheel, which turns the axle so as to raise a weight, right? Greater the diameter of the wheel, more is the advantage. It's a wheel and axle. Okay, you are actually going to put the effort on the circumference of the wheel, and this turns the axle, and that helps in raising the weight. This is the principle of wheel and axle. Now, Cryer elevator, crossbar elevator, as you can see in the picture, these are following what? You're actually going to rotate it, right? That's how you work. So, there's a wheel and axle principle that works in the wheel and axle principle. Between the tooth root and the bone and the handle is rotated, so the root is removed from its circumference of the circle, right? This is how it works. In cases where you have root tips in the socket, in order to remove that, you use this, right? Now when it comes to forceps, okay, the beaks of the forceps, you take it and apply it firmly on either side of the tooth, right? And you apply the force in the form of an arc, and this actually helps in bodily rotation of the tooth. Okay, this helps in bodily rotation of the tooth. The tooth gets rotated inside the socket, right? Haul the forceps handle. You actually haul the forceps handle, the wheel, as farther as possible. Okay, when you place your hand as far as possible, this will increase the effort. So this actually helps in extraction process. Now when you do this, okay, when you do the bodily rotation of the teeth, what happens? The periodontal ligament gets ruptured, which will help us in easy extraction procedure. Hope that was clear for you. Now we are going to a very important topic, which are the principles of complex exodontia. I hope this much part is clear for you. Please go through the slides again and see whether the topics are clear or not. Now let's see what are the principles of complex exodontia. What are the principles? What are the principles of flap design? I hope you have already studied this in periodontic classes, but still, let's see what are the principles of complex exodontia. And there we have to see the principles of flap design. We have been studying principles of flap design since 3rd year. So, yeah, what are the principles of flap design? The first one is outlined by a surgical incision. It should carry its own blood supply. It should allow surgical access to the underlying tissues. It can be replaced in its original position, can be maintained with sutures, and it's expected to heal. Right? The simple principles of flap design. Now, design parameters for flaps. What are the design parameters for flaps? So, the first one, base of the flap. Okay, the base of the flap must be broader than the free margin. Of course, yes, right. You do this in order to preserve the adequate blood supply. The base of the flap should be broader than the free margin. That's the first principle, first design parameter. Second one, flap. When you take a flap, it should be of adequate size. Okay, so that you can have a good visualization of that area and there is an adequate access for instrumentation to pass. So, yeah, that's important. Now, when you take a flap, it should be of full thickness. Now, incisions outlining flap to make our intact bone. Flap to be designed to avoid injury to the vital structures, right? You have to take care of the vital structures also. You have your lingual nerve, medial nerve. Okay, you have to take care of that also. Palatal flaps, you have to take greater care there because you have your palatal vessels there. Don't put vertical incisions, vertical release incisions in the palatal area. It's dangerous. Releasing incisions, when you're placing releasing incisions, it should cross free gingival margins at line angle to the throat. Very important point. When you place a releasing incision, it should cross the free gingival margin at line angle of the tooth. Okay, should not be placed directly on the papilla. You should not place it directly on the facial aspect of the tooth. You have to place it at line angle of the tooth. Very important. Vertical incisions, when you are going to place a vertical incision, place it only when it is necessary. Okay. Now, releasing incision, it should actually cross the free gingival margin at line angle. We have seen that already. I'm sorry for the repetition. So, these are the different design parameters. I hope this is clear. Now, let's have a quick revision on the different types of mucoperiosteal flaps. Okay. What is an envelope flap? What is an envelope flap? You're not going to put any kind of releasing incisions there. That's an envelope flap. No releasing incisions. Now, three-cornered flap. When you place one vertical incision, and that is a more preferred type, as you can see in that picture. Okay. Then four-cornered flaps, where you place two vertical incisions. Please have a look on these pictures. Then what is semilunar incision? To avoid trauma to the papilla and all, you can actually go for that. When you're going for a root apex surgery, you can go for that. Okay. Now, palatal Y incision, the last picture. It's really useful for the removal of palatal torus. Now, how do you develop a mucoperiosteal flap? What all you use? What's the armamentarium for developing mucoperiosteal flap? Number 15 blade, you can use it on a scalpel. Number 3 scalpel handle and a pen grasp. Okay. Now, sharp end of number 9 mole periosteal elevator, you can use it for the reflection at the papillar region. Broad end, we can use with a push stroke to elevate the mucoperiosteal flap. So these are the armamentarium for the developing a mucoperiosteal flap. I hope this is clear for you. It's all simple basics. Okay. Now, I hope till this part it's clear for all of you. Okay, we were only discussing the basic thing. Externship is a really simple topic. Okay, really simple chapter. We are only going through basics here. Okay, I hope this is clear. So please have a look on the previous slides before going to the next slide. Okay. Now we are coming to the very important topic. What are the principles and what is the technique for the open extraction procedure? The transalveolar extractions. If you have a failed, okay, if you've been trying for forceps extraction and no result, then definitely you have to open it, right? Okay, when you have a very thick, dense bone, particularly the buccovertical plate, if it is so thick and if it is very dense, then you have to go for an upper extraction. Severe attrition of bruxism, so that you can't have a purchase point with the help of your forceps. In those cases, you can do that. Preoperative radiograph revealing difficulty because of the root conditions, like in hypersymatosis and all. Then also you can go for extractions, right? Okay. Then what? Divergent root, dilacerated root, hooks. Okay. Close proximity to the sinus floor, extensive caries, especially root caries. In all those cases also you have to go for open extraction, transalveolar extraction. What are the steps in transalveolar extraction? First, what do? You'll give a local anesthesia. Now we will have a class on local anesthesia as a separate topic. So first you give a local anesthesia. Second thing, what? You'll incise. You will give the incision first, right? Then you will reflect the flap. Then you will do the bone cutting. You'll take your burr or with the chisel mallet procedure, either of that you will use, and you will cut the bone there. For cutting of bone, you have two procedures available, techniques available. One is guttering and the other one is postage stamp technique. Postage stamp technique means what? You will put a lot of dots and you will join that. That's a postage stamp technique, or you can use a guttering technique. And whenever you use a burr, it's very important that it should be done under saline irrigation. You have to do that in order to prevent what? Necrosis of the bone. So it's very important. Sectioning of the tooth, if it is required, you have to go for sectioning of the tooth. Usually for multi-rooted teeth, you do the sectioning. In case of grossly decayed tooth, the root may be separated at a furcation using the burr, and individually you will take two parts. Okay, then you will do elevation. You will elevate it. Now after removal of the tooth, what's the next point? You will smoothen the sharp edges. If there is some sharp edges, definitely you have to smooth it, right? To avoid what? Further trauma. You have to address the bleeding points, right? Then debride that area, suture that area. These are all the steps. Is it clear? Now what do you do for post extraction care? First thing, cure it, right? If there is some periapical lesions or presence of fractured crowns, fillings, whatever it is, cure it that socket first. Okay, then expanded buccolingual plate, you have to compress it back, right? Use your finger pressure and do that, right? Use your finger pressure and compress it. If there is some sharp bony projection, as we have seen in the last slide, just smoothen that area with a bone file. Then if there is initial hemorrhage, definitely there will be an initial hemorrhage, right? First of all, you can actually control it by a moistened gauze over that extraction socket. You can put pressure over that area. Initial hemorrhage you can actually control. Okay, now what are the complications? Definitely you can have a lot of complications, right? It's not that simple procedure. Definitely there will be some complications. What are the complications? One, fracture, crown or root, tooth root. Root displacement. Where can it get displaced? First thing, to the maxillary sinus. If it's a maxillary molar, definitely there is a risk, right? Small root fragments, if it does the sinus with no pre-existing infection, just let it be there. Okay, don't disturb it. Let it be there. If it's a very small fragment only, then only. Now, if there is an oroventral communication caused because of the root displacement, then you have to close it with sutures or flaps. Okay, don't leave it like that. Advice now, sinus precautions now, antibiotics, then nasal drops. Right, if it's a very larger root or tooth getting displaced to the sinus, you have to remove it by Caldwell Loop approach. We will see that in sinus, maxillary sinus portion. Okay, and you do this Caldwell Loop approach in the canine fossa region. Is it clear? Displacement of impacted maxillary third molars posteriorly into infratemporal fossa. It can get into the infratemporal fossa as well, right? Displacement into submandibular space. Okay, sometimes the tooth can get lodged into oral pharynx also. We can't predict what's going to happen. Okay, these all are the complications. Now there can be injuries to the adjacent teeth, fracture of adjacent restoration, luxation of the adjacent teeth, extraction of the wrong teeth. Okay, these all are some problems, right? Now, osseous structures can also get injured, right? Due to excessive force. Okay, in those cases, there can be fracture of the alveolar process. Sometimes fracture of maxillary tuberosity can also happen when you're trying to do the extraction of the maxillary third molar. That can also happen. And in all these cases, it's very important to check whether there is any oro-antral communication when there is a fracture of maxillary tuberosity. Okay, then to the regional nerves, there can be injuries, right? Fundamental nerve, the inferior alveolar nerve, lingual nerve, buccal nerve, nasopalatal nerve. You have to take care of your vital structures. It's very important, guys. Okay, you have to take care of your vital structures. Injury to TMJ. Uncontrolled force can lead to injury to TMJ, right? Okay, whenever you're going to apply force, give adequate support to the lower jaw. Then only do the extraction process. Otherwise, it's really bad. Okay, you have to take care of it. Give support, then extract. Otherwise, there can be injury. Now, what is a dry socket? Also known as alveolar osteitis. What's a dry socket? Have you seen any patient coming to a clinic with a dry socket? The patient will be in a really bad situation. Patient will be saying, like, I can't control the pain. The patient might be crying all the day because the patient is having uncontrollable pain. Okay, it's actually characterized by acutely painful tooth socket containing bare bone. It's bare bone, guys. It's bare bone and broken down blood clot. It's mostly seen in mandibular extraction cases. Initially, the clot will be having a dirty gray appearance. Then it will disintegrate. And in short, after this, you can see a yellow bone socket over there. And that's extremely sensitive area. Separation is generally actually absent, but you can have a very foul odor. Radiating pain will be there, and usually this starts only after third day. It's not immediately after the extraction. Okay, it's after third day or fifth day. Okay, that's a very important point. When a patient comes to you and tell you that I'm having pain, I had an extraction 3 days back, and when you tell the patient to open his mouth or her mouth, you feel that there's a very bad odor. So it's clear, guys. Then look for the socket, and if you can see the bare bone which is extremely sensitive, it's clear that is a dry socket case. I hope this is clear. Now, what are the causes? Trauma to the bone during extraction can be because of decreased bleeding due to hemostatic effect of the epinephrine, right? You see that in local anesthesia. Now, it can be because of infection entering the socket after extraction, presence of dense bone, loss of the clot due to rinsing of mouth. These all are some causes. Okay. Now, let's see what is Burns hypothesis. Okay, this is Burns hypothesis. As you can see in the picture, you can see the doctor is going to do, or the doctor is undergoing an extraction procedure, right? He's using a forceps there. So when you're using a forceps and when you're doing an extraction, definitely there is trauma. So trauma, right? This trauma is going to cause an infection, or it can be because of infection. So this trauma or infection is going to cause an inflammation of the bone marrow. Definitely, yes, right? And this actually releases tissue activators. And these tissue activators convert plasminogen into clot to plasmin. I hope plasmin, plasminogen and all are clear for you, because we have been studying about this since first year in physiology. So I'm not going to repeat the whole thing now. I hope you remember what is plasminogen and what's plasmin. Now the plasmin dissolves a blood clot. Okay, the plasmin dissolves a blood clot and releases kinins from kininogen which is present in the clot. And this leads to severe pain, guys. Severe pain. Okay, now when you take the culture, you can see mixed infection there. Fusiform bacilli, Vincent spirochetes, mixed infection. That's what you can see there. Okay. So the next hypothesis is a Nittizen's hypothesis. So Nittizen et al. Showed a possible significance of anaerobic organisms like Treponema denticola, okay, which are also the predominant organism in pericoronitis in relation to the etiology of this alveolar osteitis. He observed high plasmin-like fibrinolytic activities from the cultures of this anaerobe, that is Treponema denticola. Okay, and that plasmin-like fibrinolytic activity results in what? Definitely clot dissolution. Okay, I hope this is clear. Now when it comes to the treatment part, the first thing that you have to do for the patient who came to your clinic with a problem of alveolar osteitis or dry socket, the first thing that you have to do is irrigate that socket first. With a warm sterile saline or a dilute solution of hydrogen peroxide, just irrigate that area and remove all the necrotic materials from there. And after that, you can apply an Optendent, that is a eugenol or topical anesthetic pack, and a sterile gauze. Then definitely you have to give analgesics because the patient will be in high pain, right? Then after that, after 24 hours, you re-examine that socket and see whether the pain persists or not. If the pain persists, then repeat this. The irrigation, the dressing and everything is repeated again. The very important part is you should not do curettage here. Okay, curettage is never employed as a treatment. And if separation is present, you can administer systemic antibodies also. You can give systemic antibodies to the patients also. So this is how you treat. Okay, this is how you treat alveolar osteitis or dry socket. I hope the session was clear for you. So if you have any doubt, please feel free to contact us on BluepenOnline. BluepenOnline provides learning aid for MBBS, BDS, MDS, BMS, BPT, BHMS and nursing students. Nursing subject tuitions, lecture notes, university exam rush-up classes, extensive subject discussions and university exam answer sheet discussions and tutorials. So all these are available in the BluepenOnline. So feel free to contact us. Thank you. Let's meet in the next section.